Again, my name is Zachary Eagle. I'm one of the third-year fellows at BAMC. And Dr. Patel asked me to give this lecture this year, so I'm excited to give it to you. And when I was sitting down to kind of make these slides, I realized that there is a lot of nuance, and this is certainly a disease process that when I see it pop into the clinic, I always kind of have a deep sigh, because these patients can be very difficult to manage, and sometimes the diagnosis, if you don't have it already, can be difficult to make. So to give you a quick outline of where we're going to go, what we're going to discuss, we'll go over the risk factors, genetic predispositions, clinical features, so on and so forth. I do want to draw your attention to the fact that most of these slides are going to take recommendations directly from the ACG 2020 guidelines, with a smattering of recommendations that were from the 2021 Japanese guidelines on chronic pancreatitis. Additionally, there's a lot of nuance between chronic pancreatitis and exocrine pancreatic insufficiency, or EPI. We'll talk a lot about chronic pancreatitis with some slides sprinkled in about EPI, because they are closely related, but they're separate entities, and we'll get into that here in a little bit. To start, there's been a paradigm shift with regards to how we view chronic pancreatitis and how we manage it. Traditionally, we thought of it as an irreversible inflammatory condition. Nowadays, we're focusing on an early diagnosis with the end goal of changing the trajectory and changing the natural disease course. So ideally preventing the long-term complications that you can have from chronic pancreatitis over time. This slide is again to kind of reiterate the point that exocrine pancreatic insufficiency and chronic pancreatitis are separate entities. There is a lot of overlap, and patients with chronic pancreatitis can develop exocrine pancreatic insufficiency over time, but they can be diagnosed separately. You don't need to have chronic pancreatitis to have EPI. Conversely, you don't need to have EPI to have chronic pancreatitis. I think that was a point that I didn't quite get, especially in my internal medicine residency training, and it becomes a little bit more clear as you get into subspecialty training. But the diagnosis, the management, it's different between the two. And again, I'll kind of iterate on that a little bit more later. So with regards to epidemiology, no presentation is complete without a slide that goes over epidemiology. The main point here that I wanted to draw your attention to is that 50% of patients with chronic pancreatitis will have ever had an acute episode. So you don't need to have acute pancreatitis or a history of it to develop chronic pancreatitis. And as a matter of fact, 50% of the patients, they're not going to have that type of history. So again, if you have a patient with the appropriate risk factors and their suspicion is high enough, even if they haven't had an acute episode of pancreatitis, it's not unreasonable to keep that on the differential. Just a brief kind of introduction to the risk factors. Whenever people think of pancreatitis, especially providers, we're going to think alcohol consumption. That's by and far the most common cause of acute pancreatitis and chronic pancreatitis, especially in the US. But generally speaking, as far as risk goes, if you have a heavy alcohol user, so 80 grams of alcohol on average per day over 6 years' time, or alcohol consumption that directly causes symptoms associated with pancreatitis, those are the folks that you're thinking of as far as like risks. Tobacco use in general combined with alcohol will increase your risk for pancreatitis. However, it is an independent risk factor as well. To really hit home this point, these are two modifiable risk factors. A lot of patients that have chronic pancreatitis and drink and smoke have no idea that this is something that causes pancreatitis. When you ask the average person, what are you thinking of when you think of strong alcohol use or heavy alcohol abuse, they're going to say cirrhosis, which is not unreasonable. Most won't understand pancreatitis as well. It's not in their mind. Similarly, with tobacco use, they're going to think COPD, lung cancer. But again, chronic pancreatitis is a known effect from these toxins. So counseling on the front end can save a lot of heartache on the back end, and it can kind of hopefully drive home the point that cessation is important, especially with these two toxins. Other causes include metabolic disorders, diabetes mellitus, hypercalcemia, hypertriglyceridemia, chronic kidney disease, pancreatic duct obstruction, autoimmune pancreatitis, and genetic predispositions, which we'll talk about the specifics of those coming up. Ideally, this key concept from ACG is going into the comprehensive review of all patients that you suspect chronic pancreatitis for. History can kind of unroof some of these causes, and it can give you, again, risk factors to hopefully modify or targets to treat if they have a treatable cause of pancreatitis. The 2020 guidelines that ACG put forth does go through this TIGARO checklist, and it gives you a really good framework to focus on as far as trying to figure out what risk factors or etiologies your patient might have. I'm going to hit on the red highlighted ones as opposed to the idiopathic and the recurrent acute. Idiopathic is kind of self-explanatory in that you've done your evaluation, you've looked for other causes, you haven't found it. Idiopathic is kind of what you're going to be putting as the cause. Recurrent or acute pancreatitis or severe pancreatitis, again, these are going to be overlaps with the other causes or etiologies. You can have severe episodes, a single one that can lead to chronic pancreatitis, or you can have recurrent episodes from these etiologies that cause chronic pancreatitis. So I'm not going to hit on that point too much. This table is here purely to let you know that it's there. When I first saw this, especially as like a first-year fellow, I'd start to like get a little bit diaphoretic, breathe heavy. It's like, oh man, I got to memorize this whole table, and that's not necessarily the case. I think as you deal with more subspecialty type problems, knowing that there's guidelines out there is extremely important, because these can be rare patients. You might not see them every single day. So staying like up to date on it can be difficult, but knowing where to go, especially if you have questions or you need to get a framework to go by, is important. And this is a really good place to start. So again, we don't need to go over the specifics of each and every single one of these. That could be a massive talk in and of itself, but I am going to hit the high points with each of these. So moving on into the toxin side of things, again, alcohol use, as we alluded to earlier, very common cause of acute pancreatitis, and 50% of patients with chronic pancreatitis, this is the cause. Less than 5% of heavy alcohol users are going to go on to develop chronic pancreatitis, but as I was alluding to, it's the cause in 50% of patients with chronic pancreatitis. This next bullet point kind of makes sense logically. If you think about it, you've already got like a toxic insult in the form of alcohol use. So if you're combining those insults, it is kind of an additive effect. You can have genetics that predispose you to pancreatitis, high-fat diet, smoking, et cetera. And again, counseling those patients on the modifiable risk factors can prevent that progression to chronic pancreatitis. Another interesting point here, just with regards to progression. So a lot of patients with alcohol use will have these recurrent episodes of acute pancreatitis, and generally speaking, that's like a 5 to 6 year course where they're developing abdominal pain that can become more chronic, or they can start developing extreme pancreatic insufficiency. So generally, there's a little bit of a progression in these patients. Stopping alcohol use does reduce the chance for recurrent acute attacks, and it can help with the pain, but there is some debate on whether or not, like once the disease course is actually progressed enough, whether or not that trajectory changes once you stop alcohol use. Our next toxin, at least the, again, common toxin that we think of, smoking, independent risk factor. More often than not, 90% of patients with alcohol-associated chronic pancreatitis are also smoking. It's going to predispose you to pancreatic calcifications and more rapid development of calcifications. The risk for chronic pancreatitis is about 3-fold higher in patients that are smoking as opposed to patients that are not. And similarly to, everybody's kind of clanging association with tobacco use is lung cancer, really cancer of all types, you do increase your risk for pancreatic cancer and overall mortality with chronic pancreatitis when you have tobacco on top of whatever insults you have, or even if it's the independent risk factor here. Again, another kind of text-heavy slide here with regards to genetics. The whole point of this is, again, to know that these exist. There's a few major points that the ACG 2020 guidelines point us in the direction of as far as causes of genetic pancreatitis. I'm going to hit on the ones that I've seen more often than not in our literature, and it's kind of biased towards what I see on our ITEs and in training exams. But again, the key recommendation here from ACG is essentially if you've done your evaluation on a patient that has chronic pancreatitis or even an acute episode and you cannot find an etiology, it's not unreasonable to go down the genetic evaluation to see if there's a genetic predisposition, specifically in younger patients as well if they have chronic pancreatitis. And we're talking less than 35 years of age, not unreasonable to go down the genetic evaluation pathway. So starting with the serine protease 1 gene mutation, or PRSS1, this is an autosomal dominant gain-of-function mutation. This is where that family history is very important. It's going to be passed down from generation to generation. But in particular, this mutation is going to encode for a trypsinogen, a cationic trypsin that activates prematurely these enzymes within the pancreas. Ideally, they should be activated outside of the pancreas in the duodenum, but in this particular case, with the overexpression, you get autodigestion because of these activation of pancreatic enzymes while they're inside the pancreas itself. There's a few different loci of where these mutations can occur on the gene itself that account for 80% of the hereditary pancreatitis syndromes that you may see. Again, not necessarily well understood why and how these particular locations affect the expression of trypsin, but it's what we're seeing in literature now. We're getting a little more research on it. SPINK1, or the serine protease inhibitor Cazal type 1 gene mutation, is autosomal recessive. These are going to be the two that we hit on. Again, history is going to be important with these patients as well. In opposition to the PRSS1 gene mutation, this is actually encoding for a trypsin inhibitor. So ideally, trypsin does have an off button in the form of these trypsin inhibitors, but whenever you have this mutation, that inhibitor is gone. So you get this current and like pretty much unrestricted feedback loop, essentially, of trypsin activating enzymes within the pancreas causing autodigestion and pancreatitis. Risk is increased by up to 23% in patients that have this gene mutation. And again, the mechanism for this one, especially when you look into other loci of where this mutation can occur, isn't necessarily well understood. To drive home the point of modifiable risk factors when you have genetic predispositions, these are exceedingly hard to treat in that we can't really fix the gene once it's there, but you can fix risk factors. So again, alcohol use, tobacco use, you really do want to start counseling these patients because they're already at a disadvantage compared to the general population. So again, stopping those insults on the front end can lead to a lot better outcomes, or at least delay progression over the long term. Getting into autoimmune, or the A from Tagaro. So we're looking at type 1 and type 2 autoimmune pancreatitis, really the two types that are outlined in the guidelines. Type 1 is going to be associated with our older patients, generally speaking 6th to 7th decade of life males. It's usually a disorder of IgG4 disease, and it's a syndrome that affects multiple different organ systems as opposed to just the pancreas. Usually when you get labs in these patients, you'll see an elevation of IgG4 as opposed to type 2, which presents in younger patients, affects males and females equally. Those IgG4 levels in type 2 tend to be mildly elevated if they're elevated at all. Interestingly enough, with type 2 autoimmune pancreatitis, it seems to be limited to the pancreas, but it does seem to co-occur in patients with inflammatory bowel disease, so ulcerative colitis, Crohn's. That can be extremely difficult when you're talking with patients that have poorly controlled IBD. They're going to have lots of pain as it is, but if you have patients, again, that their IBD seems to be very well controlled, but they keep complaining of abdominal pain, especially younger patients, this is something that you can keep on the differential as a possible cause. I don't go too deep into the management of autoimmune pancreatitis, but if you go back and look at the table that I had with the Tagaro guidelines, this is kind of classified as a steroid-responsive pancreatitis, and that's generally how you're treating these patients, with very long steroid tapers, almost similar to autoimmune hepatitis. A lot of patients don't necessarily tolerate coming off of these tapers, and when that occurs or they have steroid refractory disease, there are secondary medications that you can use. Rituximab is outlined as being beneficial, and mycophenolate mofetil or Cellcept can be used as alternative methods, especially in patients that are not tolerating coming off of steroids. So obstructive pancreatitis, one that's near and dear to my heart because I like fixing obstructions. They can be a number of different types of obstructions. Congenital causes, which I have here from pancreatic devisum to gallstones. You can even have pancreatic cancers or malignancies that can cause acute obstructions and acute pancreatitis. But in particular, with regards to this slide, the top left, if you see the normal pancreatic ducts, you'll have your minor papilla and your major papilla. That duct of Santorini is a very, very small duct on the dorsal side that drains through a very small minor papilla that can accommodate a smaller duct. Whenever you've got pancreatic devisum, the dorsal duct is actually the main pancreatic duct where all the pancreatic enzymes and juices drain into the small intestine. And when you have all that trying to drain through a very small valve in the form of your minor papilla, it can cause obstructive symptoms, it can cause pancreatitis, and it can cause a lot of inflammation over time. The way that we treat this is a little bit more debatable, especially depending on the patient population. Sometimes you can do stents, sometimes you can open up that papilla to try and help drainage through the pancreas. But the side effects of doing these interventions on these patients, especially ones that require incisions, essentially with the ERCP scope, does increase your risk for developing acute episodes of pancreatitis. So these patients can be at a little bit higher risk. But generally, again, if you're seeing young patients that are developing pancreatitis, this is another instance where you can kind of look at the imaging yourself if you have the ability to, or ask your radiologist to review it with you and see if there's any evidence of devisum that's present. Gallstones, which Dr. Santos will be talking to you about next, is another very common cause of acute pancreatitis. And interestingly enough, the most severe cases of pancreatitis that I've seen have actually come from patients with acute gallstones. Those have been the ones that have gone on to develop severe pancreatic necrosis, and that one severe episode has kind of led to chronic pancreatitis after the fact. The treatment for this is very similar to how we treat choledocholithiasis. Generally, this is usually occurring hand in hand, is just opening up that ampulla and letting those stones drain out and getting the gallbladder taken out. The whole idea behind managing gallstones early is, again, preventing these recurrent episodes. You can have microlithiasis or small gallstones that you don't necessarily see that are causing obstructions as well. So we do have guidelines that suggest if you have any evidence of microlithiasis or sludge within inside the common bile duct to try and get those out. Reason is kind of multifactorial, but there's some instances in some literature that suggest you can get chronic pancreatitis, and others that kind of mention that you can have a secondary type sclerosing cholangitis in the liver. But since we're focusing on the pancreas, I will not hit that point too much. So the clinical features, and again, I apologize, chronic pancreatitis doesn't really lend itself very well to like nice pictures. So a lot of these slides are text heavy, so bear with me. So abdominal pain is going to be the most common clinical symptom that we think of, and more often than not, that's what's driving your patients to the clinic. As opposed to acute pancreatitis, the actual like characteristic pattern of pain isn't necessarily well defined for chronic pancreatitis. When you think of acute pancreatitis, you have that abdominal pain radiates to the back, and it's generally pretty common amongst patients that come in with acute presentations. In chronic, it can vary from patients to patients. The natural history will also vary as well. Some patients may have episodic pain. Some patients have a more gradual pain that's not necessarily episodic, but is always present and just continues to progress and progress and progress over time until it's severe and persistent. Interestingly enough, other patients may have pain that gets really, really bad over time and then dissipates. That occurs about 50% of the time. We can't forget that the pancreas is, again, an exocrine and an endocrine organ. So exocrine deficiency, or EPI, as we were alluding to earlier, can lead to fat malabsorption, fat-soluble vitamin deficiency, malnutrition, and related conditions from fat-soluble vitamin deficiencies, such as osteoporosis. Endocrine dysfunction manifesting as diabetes mellitus can also occur. At this stage, it's thought of that the chronic pancreatitis is pretty much irreversible, and preventative or restorative therapy isn't necessarily possible at this point. So again, we want to find this diagnosis early and prevent the trajectory to getting to this point. A lot of patients that you'll see are a little bit later in that disease process, which can make this a very frustrating clinical syndrome to treat, in that you really are hoping to catch these patients early. So if you have any inkling or if this is even a suspicion, it's good to try and, again, modify those risk factors where you can, or treat any treatable causes as you can. Malignancy is also seen more commonly in patients with chronic pancreatitis. I'll touch on this point a little bit more, but as of now, there's no guidelines that state if you have a patient with chronic pancreatitis that you're obligated to do any type of like serial imaging. There hasn't been any data that suggests that it's beneficial in chronic pancreatitis, and I'll hit on that point in a little bit later on in the management portion of this lecture. As far as the initial approach, again, text-heavy slide, but hopefully it'll give you kind of an outline of how to talk to these patients and really where to start your evaluation from if it's on your differential. History is very important. Sometimes patients will come with like a big giant flag that's like, this is chronic pancreatitis, and it's very easy to make that diagnosis. Other patients, especially younger ones, it might be a little bit more nuanced. But in addition to that, I used to have an attending that was a very good, now colleague, I guess, it was my medicine attending, that would always say there's usually multiple monkeys causing the problem, or multiple monkeys on your back, and you got to figure out which one's the biggest one to pull it off and fix your problem. So it might not just be like toxins, but you might have a genetic predisposition, you might have autoimmune pancreatitis, and you're smoking. It can be multiple different features. So it's important not to just hang your hat on one particular cause, and really try and evaluate the patient thoroughly to, again, prevent the progression of this disease process. So again, we're going to start with the Dagara system. It does help provide that framework, as I was alluding to earlier. You're going to want to get dates of onset of diabetes mellitus if the patient has it. Maldigestion or malnutrition, any evidence thereof. A lot of patients will come to you with labs that are already drawn. Take a look at them, see if you have high calcium levels, see if you have any fat-soluble vitamin deficiencies, see if there's been any evidence of bone fractures, especially in younger patients, males, that is a little bit atypical. See if they have osteopenia, osteoporosis. Again, it just kind of will help you expand the differential a little bit and maybe give you some clues as to what's going on. History will be important, especially when you start getting into these genetic disorders, particularly cystic fibrosis. That's going to be in your younger patients, and that's where family history comes into play. So you're going to go out to at least your third-degree family relatives. You're going to be asking about pancreatitis in family, cystic fibrosis, diabetes mellitus, pancreatic cancer. Biomarkers that you can use to help, again, elucidate what's going on is going to be calcium, triglycerides, fat-soluble vitamins. Amylase and lipase can be beneficial as well, albeit sometimes your lipase may not be elevated in chronic pancreatitis, but certainly with your acute episodes, that can help, again, clue you in on what's going on with your patient. If your etiology is unclear, and this was, again, going back to that key point from ACG on the genetics causes of chronic pancreatitis, or if you have a young patient less than 35, or you're having recurrent episodes and you can't figure out why, refer them for genetic testing. This can be frustrating in that there's not a lot of access to geneticists. I think like our lead time for a referral to a geneticist at BAMC, and we've got pretty good access for most specialties, is like 3 to 6 months. But in that time period, if that's even on the differential, again, hit those modifiable risk factors and try and see if you can help manage them from a separate standpoint as you're awaiting the geneticist to do their evaluation. I promised some slides on exocrine pancreatic insufficiency. Again, related to chronic pancreatitis, but not necessarily, it doesn't necessarily, you don't need to have chronic pancreatitis. It ranges in about 40 to 75% prevalence in patients that do have chronic pancreatitis, so it kind of does go hand in hand. It's highest in those with pancreatitis due to alcohol or tobacco use. When you're thinking of exocrine pancreatic insufficiency, you're going to start looking for changes in bowel habits, steatorrhea, fatty diarrhea, essentially, looking for evidence of fat-soluble vitamin deficiencies. Again, vitamin D, osteopenia, osteoporosis, especially in younger patients. And again, normally these patients, when they get to this point, are going to be having abdominal pain as well as exocrine pancreatic insufficiency. But the key concept here, and I know I've been hitting this like kind of hard, again, straight from ACG, is pancreatic function testing is an important means of diagnosing exocrine pancreatic insufficiency, but its role in establishing the diagnosis of chronic pancreatitis is complementary and it's not required. This slide is again something so you know that it's there. We use fecal elastase testing more often than not, pretty much with all of our patients that we're looking for EPI. There are CCK stimulation tests, secretin stimulation tests, and if you look through the literature and the guidelines, a lot of people will refer you over to these different types of stimulation tests. They're extremely burdensome. They're very technical. There's a lot of variability to the institutions that even do it. We don't do it at BAMC. I've not seen this done before, but some of these more specialized places may offer it. This is just so you know kind of why this isn't done commonly. When you do secretin stimulation testing, you can have either a drilling tube that's on the top slide, or you have to do an endoscopic suctioning of duodenal juices, essentially, to measure the pancreatic secretions. So it's not a simple test. These can be hours long. It's a lot of work on the patient, but also you're likely not going to have it at whatever institutions you're practicing at unless you're at huge academic centers. So fecal elastase is generally where we're relying on for diagnosing EPI, or at least helping us make that diagnosis. A very quick physiology review. I think this was like my least favorite thing in medical school, and it still kind of remains that way today. I like fixing the problems, but understanding how those problems come into play is very important. So I'm hitting the bottom bullet point kind of more specifically because that's how the secretion of these pancreatic enzymes occur. But generally, you have peptides in the duodenum that occur from dietary intake. CCK is secreted from your eye cells, which are going to be located in the proximal portion of the small intestine, proximal portion of the duodenum. That then causes zymogens to release from pancreatic acidic cells, which these are inactive pancreatic enzymes. Once they hit the duodenum, they're activated by trypsin into active enzymes, but this is kind of where things tend to break down as far as genetic predispositions, or if you have blockages or obstruction within the pancreas itself, you get this autodigestion because of premature activation of these zymogens into active pancreatic enzymes. So fecal elastase, which is, again, secreted by the pancreas whenever you do have stimulation from those CCK cell, or from CCK secretion from eye cells, is going to be the way that we look at EPI as far as making the diagnosis, or at least, again, cluing us into what's going on. It's generally speaking inaccurate between 100 to 200. You got to be careful when you're using fecal elastase in patients that are having chronic diarrhea, as that can cause false positives. And generally, if you've got a level that's less than 100, it's very specific for exocrine pancreatic insufficiency. And in those instances, you can start thinking about management, and I'll talk about that in kind of one of my final slides. You may see some data suggesting a 72-hour fecal fat measurement to actually diagnose steatorrhea. It is offered in some institutions. Again, burdensome to the patient if you're thinking about collecting stool for 72 hours. The fecal elastase is, generally speaking, friendlier and a little bit easier to do in again, a simple lab that you can submit into the computer. Lab will take care of the rest, and you don't have to worry about the headache of anything else associated with collection. So you have a suspicion for chronic pancreatitis. You've got the clinical features. You've got the risk factors. You've gone through kind of the Tagaro checklist. If you're using it, you've got biomarkers. How do we make our diagnosis? This is the outline that ACG has recommended in the 2020 guidelines. It starts with cross-sectional imaging, so your suspicion for chronic pancreatitis is there. You're going to reach for a CT scan or MRI to kind of see if you have any changes consistent with chronic pancreatitis. We'll get into those changes on the next couple of slides. If that imaging study is negative, you're going to move on to the next imaging modality of choice, endoscopic ultrasound. If that's negative, you can move on to secretin-enhanced MRCP. And if you're still convinced this patient has chronic pancreatitis, but none of these imaging modalities are giving me a diagnosis, you can perform genetic testing at that time. If it's positive, then you're going to want to get pancreatic histology. Again, your imaging was negative as it was, so you need to figure out, if there is actual evidence of inflammation of the pancreas. If that's positive, or any of these tests that were done beforehand are positive, then you've got a diagnosis that's consistent with chronic pancreatitis, and you can manage them as such. If all that's negative, maybe we need to start thinking about something else as their cause of pain and move away from the chronic pancreatitis as the cause. So with regards to our diagnostic criteria, at least when we use EUS, and a lot of the EUS findings are very similar to CT findings or MRI findings, we're looking for calcifications within the body of the pancreas itself. We're looking for evidence of stranding. We're looking for evidence of pancreatic duct dilation, even hyperechogenicity of the duct wall, which is really where these pictures come into play. Knowing the criteria, at least EUS criteria, is not necessarily something that you need to do unless you're an advanced endoscopist or doing EUS. We have Rosemont criteria and standard criteria that has been well researched. But again, if you're looking at the pictures on your own, especially when you have access to CT scans or MRIs, this can really help you without having to order additional studies. Or you can go and again review this with your radiologist. A lot of the times you'll see imaging that's done for other reasons, pulmonary nodules that might catch part of the pancreas. Radiologist isn't necessarily looking at the pancreas in those instances, they're looking for nodules, but you may be able to kind of, again, get some data points and at least clues as to what's going on before you get dedicated imaging. So this shows pictures of dilated main duct, which is in the top left, the hyperechogenic wall in the middle, and then echogenic stranding instead of that nice homogeneous appearance that you should see of the pancreas. This is actually looking at a CT scan of the pancreas. So you're looking at again, that thickened pancreatic duct wall, a very dilated pancreatic duct. You're looking at calcifications within the body, dilated side branches. In general, you can look at this picture and say something doesn't look right. You don't necessarily need to memorize the criteria, but again, you can reference it again to see if they're meeting all the criteria, at least by CT grading, to see if they have chronic pancreatitis. And in general as well, you can also look at just the body of the pancreas, the tail, and just see if there's a lot of atrophy that's present. And again, that can clue you into what's going on with your patient. This is actually an ERCP that's being done for therapeutic purposes on a patient with chronic pancreatitis, and that gives you this Clang association of the chain of lakes appearance. I've seen that pop up a few times on my own training exams. Haven't quite seen this pretty of a picture when we've done our interventions on patients with pancreatitis, or at least chronic pancreatitis, but you may see this picture pop up when you're doing your literature review, or if you have any in-training exams that y'all have to do as well. More pictures is kind of showing a lot of the same, and again, to try and break up the monotony of text-heavy slides. This is showing, again, main pancreatic duct dilation on a pancreatogram, dilated side branches, that chain of lakes appearance, a beaded appearance. This is chronic pancreatitis. So again, to try and keep this within 30 minutes, you could have a multiple hour-long sessions just with the diagnosis, the management, and the genetic causes. But I wanted to kind of summarize management in one slide. That way you kind of have something to refer back to. Ideally, again, going back to that cancer risk, because that's a common question that comes up in clinic is what is my chance for pancreatic cancer, or am I at increased risk? And the answer is yes, but so far there's not been any data to show that in patients just with chronic pancreatitis that imaging serial surveillance is providing a benefit. Now, you may have genetic predispositions to pancreatic cancer, first-degree family relatives. That changes things, but if it's just chronic pancreatitis, again, you don't need surveillance imaging in those patients for cancer screening purposes. As far as, again, modifiable risk factors goes, complete alcohol and complete tobacco cessation. Again, this improves pain. It may not alter the disease progression depending on how far along they are, but counseling is going to be really strong. Again, a lot of patients don't think of pancreatitis as an outcome of alcohol use and tobacco use. There are surgical options that you can use to treat chronic pancreatitis, as far as like opening the duct up itself, and as well as endoscopic options. The surgical options have been shown to be a little bit better as far as duration of effect, but more often than not, surgeons aren't going to want to operate on these patients until the endoscopic options have been done. That being said, it's not unreasonable to get surgery involved or to get advanced endoscopy involved if you have a patient that you want to try and see if we can offer additional therapies to. Whenever we do ERCPs, again, there's stent placement that we can do. We can break up stones within the pancreatic duct or calcifications and try and pull them out. There's various different methods that we can use to do that. There's celiac plexus blockades that we can do with EUS guidance and actually just try and block the pain sensation to the pancreas itself. That can be very beneficial in some patients. We offer it at BAMC, and I've seen pretty good results. And the nice thing is that it's opiate-free, and you can repeat it. Generally, we'll do it every 3 months, but sometimes you get patients that have longer duration of effects, and you can repeat it as needed for those patients. If it doesn't work, you've tried it a few times, you don't need to keep going down that pathway to try plexus blocks. Again, it's another tool in the box that you can use to try and help these patients, especially when it's pain that's refractory to more conservative measures. Pancreatic enzyme therapy is one that pops up as well as a big question. A lot of patients will ask, do I need to be on supplements for my chronic pancreatitis? And the short answer to that is no. The data that we have does not suggest that starting patients on Creon helps with pain associated with chronic pancreatitis. That being said, you'll have a lot of patients that come to you without EPI that are already on Creon, and they feel better on it. So there's no reason why you can't continue it. But if it's purely for pain, we haven't seen that there's a benefit, especially considering the cost associated with Creon therapy. Now, if you do have exocrine pancreatic insufficiency, you've got your fecal elastase is low, fat-soluble vitamin deficiencies, then by all means, very reasonable to start patients on Creon or lipase. You want to do at least 40 to 50,000 units with every meal. It's important that they take it during their meal, not before their meal, not after the meal, like when they're eating. And then you want to make sure that they're actually having a response. So looking at those fat-soluble vitamins, looking at micronutrient deficiencies, and making sure that it's getting better and titrating your therapy to effect. Opiates are unfortunately something that we'll see patients already on, and it's not necessarily like a no-go with these patients. As many of you have probably seen some of these folks in clinic, chronic pancreatitis is extremely difficult to treat, especially when we're progressed to a point where pain is like an everyday encounter. So if you've tried your non-invasive methods, you've tried your invasive methods, you've referred to surgery, referred to advanced endoscopy, they've undergone stent placements, and they're not really getting any better. In those instances, sure, you can try and get them on opiates, or at least in my opinion, refer them over to a pain specialist, as they're going to be seeing them relatively frequently. The last point that I want to make here before I hand off the lecture to Dr. Santos was total pancreatectomy with islet autotransplantation is something that you'll see in literature. This is the only times that I've kind of read about this being done is younger patients that have genetic predispositions, and that this is at highly specialized institutions and can be something that you will reach for after everything else has been exhausted. Again, not something that we offer here, but it is something that you can consider referring patients to, especially if you've exhausted everything else and you're at a point where management is becoming a little bit more difficult and outside of your scope, essentially. But I know that was a very text-heavy slide, a very text-heavy lecture. I appreciate everybody's attention. Hopefully you have a way to approach pancreatitis, or at least chronic pancreatitis, and you know at least a framework of where to start. Again, appreciate your time. If you have any questions, we'll have the Q&A afterwards, but I'll go ahead and hand off the lecture over to our next speaker.